Good evening, everyone. So, uh, today is day 5 of the Golden Jubilee series, and I'm Dr. Chalab Sinha. And today we have a case of a soft cataract in which it was not very easy to remove the soft nuclear material. So, here goes. I sit temporally and the side put incision being made with the MVR blade on almost 180 degrees apart, just within the limbus. The Hoskins forceps provides the counter pressure from the opposite limbus. Air is placed inside the anterior chamber, followed by trypan blue. I usually do this to protect the corneal endothelium. Air is always injected and washed through the other side port so that some of the trypan blue also stains the side port, and one doesn't have to look for it when one introduces the chopper with the left hand. Then followed by dispersive viscoelastic. This is a 2.2 keratome. A small groove is fashioned in the limbus, and then the keratome is introduced through that groove into the anterior chamber, and it is slightly enlarged. This is a Gaurav Luthra's rhexis marker to give some measurement of rhexis that is planned. So usually I rely on the rhexis marker and then raise a flap of the anterior capsule, flip it onto its surface, and slowly the repetitive movements are made that we get a circular axis. Spatula in the left hand not only stabilizes the eye, but also you can use it to flatten out the flap if required. And then the hydrodissection using a flat 25 gauge cannula. After doing some hydrodissection, visco is placed inside the eye. And this is a flared tip 2.4 millimeter sleeve. I'm using a Tinsky in the opposite hand. So here the nucleus did not rotate in spite of what I thought was a adequate hydrodissection. And because it does not rotate, your cartwheel technique won't work here. So since that failed, I've now converted it to a stop and chop. So a central trench is fashioned and it is divided. The nucleus still does not rotate completely. So a little bit more of the trench being deepened to allow some fluid to go behind and allow the tip to rotate, allow the nucleus to rotate. So I tried to catch the one pole of the heminucleus, but since the entire nucleus hasn't divided properly, it wasn't easy to hold it. So it was cheese wiring. So now I've tried to remove uh, the bridge that was there, shifting the parameters a little bit so that I can hold the nucleus. So that's why you saw me waiting for my assistant to change the parameters. Again, trying to hold one edge of the heminucleus, but I'm still not successful in bringing it up. So small fragments are coming, but not the entire heminucleus. Some viscoelastic going inside the eye. So I have a system where if the cassette fills up with water, you need to replace it with a new cassette. So probably that is what had happened here, and I had to come out and allow my assistant to change the cassette. Yeah.
At this stage, can't you do a rehydrodissection?
Yes, that I should have done that. I should
So
have done
now,
that.
because you come out in this in between time, to do that, so it will have been make the life more simple.
Simple, yes. So I didn't do a hydro, but thought that since the nucleus had started rotating, probably hydro was not required. So after the set has been changed, again gone inside to emulsify, but I think still there is a problem. So what I did now was that I use viscoelastic go behind that fragment,
Viscodissection.
viscodissection. So rather than use
That is
fluid,
still safer.
rather than using fluid, I have decided to use viscoelastic, go behind, and help that nuclear fragment to come in the center, so that it becomes easier for me to uh, remove the nucleus. So that is one trick that one can do. That if the nuclear fragment doesn't come in very easily into your phaco tip, then you can inject some viscoelastic, just like you do hydrodissection. Similar fashion, one would do a hydrodissection, but using viscoelastic. So that basically viscodissection. So that basically leaves or creates a space between the capsule and the fragment, and allows it to come into your phaco tip.
It
So
was lucky that it was the collecting chamber was full, not the bottle was empty. That would have been other danger.
yes, that is true. So the phacosurgeons, we need not only look at the eye, but also look at the fluid, sometimes look at the catching chamber, and especially the fluid. Because if the fluid finishes, then we've
The other stuff, if they see so in difficult situation, then your mind is here. He or she can take care of that. Sir, hold on, like that.
yeah, so again going in. So I'm not using any chopper in my left hand just so that there's no leak of fluid from the opposite end. Uh, this is what happens, when you change the cassette or if you change the bottle, some air bubbles do go inside. So in this case, luckily, the nucleus is out, and what I usually do is that I inject viscoelastic from the opposite end, but here I hadn't done that. But still, viscoelastic being placed in the anterior chamber, and now you know we will do bimanual irrigation aspiration. So irrigation in the right hand and aspiration in the left. Little bit of tugging it sideways for us to release it, and always it is brought to the center and then aspirated. And generally, if I can, I don't change my hands. I just keep the irrigation just behind the aspirating port so that it protects the posterior capsule from jumping up. So whatever uh, cortical material that is left behind can also be removed without having to change your hands. So see where the irrigation is. So the irrigation also plays a role, not just only giving fluid inside, but how you place the irrigating cannula also helps in removing the cortex and protecting the posterior capsule. Uh, Most often, I'm able to remove most of the fibers. Some fibers remain, doesn't matter. When we do a visco wash after placement of the intraocular lens, you can just switch the hands. Again, viscoelastic going inside. Now comes the few drops of proparacaine. Then the intraocular lens, a foldable intraocular lens is loaded. Always fill the cartridge with viscoelastic. The placement of the optic and the haptic has to be proper within the groove so that it doesn't get caught in the cartridge and break it. So the cartridge is then loaded into the injector, and then this is a wound assisted implantation.
What's the wound size?
The wound is 2.4.
2.4.
Yes. And because these are not designed for 2.4, these are designed for 2.8. So just the tip goes inside within the tunnel, and it is pushed inside.
Did you ever encounter despent detachment for this?
No, I haven't had a distance detachment, but I've had cases wherein the uh, IOL opened outside only. It didn't. I mean, if the cartridge of the cartridge is not placed properly within the tunnel, then you may have a situation wherein the uh, the IOL unfolds outside the eye rather than inside the eye. So then one has to simply, load it into a different cartridge and injector, and then probably enlarge the incision a bit, uh, and then implant the lens. So I've had cases where it opened outside, half outside, got stuck in the wound. Sometimes the haptic gets stuck in the cartridge. So all different sorts of scenarios have happened with me. Probably in one of the series, I will present only those uh, cases. So here you can see,
Shalab,
yes,
why don't you put the cartridge inside the chamber instead of wound assisting? What is the harm if you push it inside?
uh, just to make just to keep the wound
I mean,
to 2.4.
wound structure basic, just to maintain the wound structure probably. I mean, that is the only advantage. Otherwise, I think it is always safe to push the cartridge in the anti-HM and then push the
So
lens.
he wants to save a few millimeters.
and secondly,
and to justify himself that he is
No, no.
preventing astigmatism, he is inducing less astigmatism.
No, that's not a fact.
that is not a fact because you are going to hydrate the wound anyway, right? So the wound structure will be
Not if you don't
slightly
hydrate
different.
also. If you don't hydrate also, once you're stretching, it causes more astigmatism than a clear cut by the incision knife. So a clean knife incision will be less astigmatism than a stretching and then tearing. It's like you do a
Yes, that's right.
episiotomy and the delivery directly without episiotomy. It causes more rupture.
Yes, so the only reason for not making a 2.6 or a 2.8 millimeter incision is just to keep a smaller incision, only to prevent the most dreaded complication, that is endophthalmitis. The
Okay, yeah, that is an
advantage of
advantage. That is an
the
advantage.
advantage of the wound size has only one advantage, and that is smaller the incision, the lower the chances of endophthalmitis, because the size of the wound, if it is larger,
Shalab,
it can tend to
that means
leak.
Shalab, that means you advocate the 1.8 incision. It has a larger advantage than the 2.4 and 2.8.
The problem with the 1.8 incision is that most of the Indian nuclei, it is very, very difficult to remove the Indian nuclei through a 1.8
But
millimeter incision.
if you choose the right kind of cataract, I think 1 point because I do 1.8, not lot, but I think 10% of my cases are 1.8. That is
Yes,
after picking
so
up
again,
the right kind of cataract.
You are
yes,
an elite
yes,
surgeon.
yes, yes. So
That is because the platform, the machine that I use has a platform of 1.8, and the lenses are also available. The Hoya has got a 1.8 platform lens, nano lens.
yes, yes.
Which phaco you are using?
Visalis fiber. Visalis.
The only point is that your patient has to be so high end that they are just doing that. Okay, my glass power is changing. I want a cataract surgery.
And second, one more thing, Shalab, what I observe while loading the lens, when you are putting the lens in the cartridge, what I do personally, that I always place the leading haptic on top of the optic and then push it in the cartridge and then then close the cartridge.
Yes,
That
I
is the
was.
advantage. Because what I saw, you just place the lens and closed. I
Yes,
think you must also be doing the same,
I
pushing
used
the
to. I
lens
used to do
such
it.
a
I
way
used to
so
do
that
it.
That is
has
another
in
cartridge. That
such
is
a
not
way
this
that the
cartridge. This cartridge will not fold. This cartridge will not take the fold. That is another cartridge. I
Uh,
don't remember the name.
Again,
That is Monarch cartridge, sir. That is Monarch cartridge.
Yes, yes,
so
yes.
that
no, no,
gives an
the
advantage of the fact that when the lens unfolds in the NTA chamber, it has got more control basically.
Sir,
yes,
It
what
unfolds
Shalabh
into
is
the
Dr.
bag.
Shalabh is using is butterfly cartridge. You can't do that
No,
probably.
no, you can do it in the
no,
butterfly
you can do
cartridge.
it.
You can do it in
No,
every
no, you can
cartridge.
do it.
You can
You
do
can
it
do
in
it.
every
That's not a
cartridge.
problem. That's not a problem at all.
That is not a issue. Yeah.
I used to do it a lot in the past, but then what I saw was that these are all Indian IOLs. I use more of Indian IOLs. So the thickness of the IOL and the uh, material is such that if I was loading it within the optic, if I was putting it within the optic, I was getting more of fractures at the edge of the optic, so which I thought was because that the thickness of the IOL once it closes, the thickness probably while going through the cartridge, it is causing a crack in the optic. Although it is happening
Your
at the
colleague,
edge, although it was happening at the edge, but still, I did not want to risk happening, coming in the center. So that is why I've stopped. I did it for a few months.
you,
Many
Like
cases,
you
like
nothing
can
like
do
happened.
this solid cell. You can do this
for the
solid cell.
Alcon IQ IOL, I mean, it can easily be done.
Yes, so
You
in
can
those, yeah,
cut the tip of the thing in one side, the lower side. So that
Yeah.
will do two things. It will not have any break of the eyewear. It will always go inside the bag and then it opens. So
yes.
inside the half of it, you cut a lower part and then it will go perfectly in the same place. And no eyewear will ever be damaged.
Yeah, so that is the design of the cartridge is such that it is not meant for putting it over
But
the
then
optic.
you may not win some beautiful prizes of the video because those videos get the prize. Okay.
No, Dr. Shalab has won all the prizes, so he does not require now any prize.
No, the more the merrier.
No more than
Once
that.
you taste it,
I
you know
still,
how good it is.
The
I,
society awards only one prize, so he is not going to get the second time.
No, the whole world is there, so he can get so many. The more complications, the more prizes.
Okay, next trip will be Dubai. A prize in Dubai.
okay. So what I wanted to show today was, there can be situations wherein you have a very soft cataract. It converts into a bowl, doesn't come in very easily. What you can use is you can use visco and dissect it and bring it to the center and then bring it out. Uh, you don't have to, keep trying to catch it at the edge because there are very high chances of creating a posterior capsular rent. And most of these soft cataract patients are all young patients, and if you have a PCR, the chances of then the posterior segment complications are going to be there. So
Shalab, one query at this point. What
yes,
kind of a pulse you like to use for soft cataracts?
uh, generally it is not on pulse because pulse will, once you hold it and if there's a break in the vacuum, then it is going to leave it. So when you're using a soft cataract, there's no need of pulse. I think it has to be in a continuous mode where it just goes and catches and brings it to the center. If it is in a pulse mode, then it is going to leave and then catch, leave and then catch. So that is why I don't think pulse is a good idea when doing a soft cataract. Pulse is a good idea when doing grade 3, grade 4, because you
No,
want to
grade 3, grade 4
optimize
is all right. You use a higher pulse. You use a pulse of 40, or if the machine allows more,
more.
you can go up to 120 pulse. Yeah.
So
For softer cataract, I
yes.
basically use a Venturi machine, Venturi
So this is
platform. I mean, 99.
whatever surgeries I'm
So
showing
I
also on Venturi only.
Okay, right.
Mm.
So for the venturi, what I have been doing for the last so many years, I use a pulse of around 4 to 6.
Yes. So,
I
soft
think
cat
I'll have
actually you
to,
don't, soft cataract, because you actually don't need a pulse. So you can keep it a
yeah,
very low and,
yeah.
or,
And low power, of course. Low power, low
low power.
vacuum, aspiration, we call it. Yeah.
Yes. Yes.
On
So,
the table, we must tell ourselves not hydrodissection. I'm going to do a cortical cleaving hydrodissection, CCH.
yes.
And if it is not from one point, I will do the other side, other point, and I will complete it, then go to the next stage. Then all this delay, all these problems are gone. Only one step, cortical cleaving hydrodissection.
Yes.
Plus
So,
minus hydrodelineation, plus minus.
so
Depending on what
actually, because
machine, what nucleus.
Dr. Sanjeet, actually, there's no nucleus as such in these cases. So there's no point of doing
So hydrodelineation is
hydrodelineation.
not important.
Hmm.
Delineation is important, but hydrodissection is always important. That should be cortical cleaving.
Yes.
Then all these delays would not have been there. Just the things are baby out and you go in and you come out. Lollipopping.
So, but in many cases, you, in spite of doing hydrodissection in multiple places, which you saw I was doing, I was not able to rotate the nucleus.
No,
Uh, because it was so
that's why I
soft.
told the word. I must tell myself that I will complete cortical cleaving hydrodissection. I will make the anti-capsule tent and then inject and give a full wave, go to the other side and depress. So I will tell myself, if I
Yeah.
cannot do from this, I will go to the adjoining area. So once
Yeah,
that part
yes.
is done by myself and I told myself, then no other delay later on.
Yes.
Yeah, exactly. That point is very important. Tenting of the rexis margin upwards
Yes.
and then pushing the fluid, that ensures
That's
that
the
the
thing,
fluid is
cortical
going to,
cleaving hydrodissection.
yeah,
That is cortical cleaving. And I said, it's so
yeah.
soft, हम तो अभी निकाल के आ जाएंगे. And that's the problem, it happens. So God smiles. Okay, I will see you.
That's a very good tip uh, that we must take home.
CCH.
Yes. So
Bas, that's it.
yes. So that's a very good tip that we have, and that is
No,
tenting
we
of the
forget. We
capsule.
forget when we go there. We forget. We forget that
Yes.
so easy. I just come out.
Yeah. So that is what happens. You are doing 4, 5 cases, or if you're a very prolific surgeon, you're doing 8, 10 cases in a day, and probably this is the third or the fourth or even the last, and you want to just finish and go home, but you forget many steps. So it's always good to keep it in your mind that one is going to
Must complete
be.
CCH. That I have to say myself, and then go ahead. And then everything gets 1/4 time, and 4 times more pleasure.
Yeah. So as you saw in this case, probably the cassette filled up, and then the bottle also got empty.
Exactly. That's the thing I'm
So
telling you.
it was
Because
one of
you are
the
smart at the beginning, I know I can do it.
so this is what happens. Probably one of the last cases you have to do, and uh, you want to just finish it off, and you forget to do certain things. So
God sent you the dusra.
so the time that you get in between, you can probably go and remember this tip that Dr. Sanjeet has given. Very, very beautiful tip, uh, which
CCH.
which we could have done if right in the beginning. Then the problem of all these problems would not have happened. So
Even at that stage when it was not coming out, if you could have done that thing around, you are doing temporarily, so around 7 o'clock, and it would have been very good. So no problem.
yeah, so inside out hydrodissection has already been described by Dr. Abhay Vasavda. Hydrodelination actually in posterior polar cataract, that you create a bowl and then
No. I'm not talking no. I'm not talking delineation. I'm talking exactly
dissection.
hydrodissection, and that separates the whole cortex mass, including the endonucleus, from the capsule, and that you require for phaco. Otherwise, the capsule get ruptured.
Yes,
You
yes,
require the capsule to totally separate it, free of the mass. Once you
yes.
do it, whatever method you feel, and that's fine.
Right, right. So thank you, sir.
So hydrodissection is really important. Although it is innocuous, people think that there is nothing, no technique or no this thing is involved, but it is really important step.
No, actually, when we are doing ECC to a hydrodissection, But when you're doing phaco, it is CCH, cortical cleaving hydrodissection. That's the difference, nothing
Okay.
more. Exactly same. In ECC, we are doing hydrodissection only. And here we're doing CCH, cortical cleaving hydrodissection. And you can do from multiple areas till it is complete. From one area, because the hard nucleus will not be complete in one area. You have to do in multiple areas because there is some cortical adhesion. But then unless you complete it, don't go to the next stage. And that we forget to adjust. अरे हम कर लेंगे.
And secondly, the fluid wave also you can see in the microscope, coaxial microscope.
Yes,
That
yes.
also gives you an
So,
indication that the cleavage has been complete.
let me just go back to that case and I'll show you one thing which should always. Okay. So now just see this. This part, this whitish part, is
So
where
we are
the.
seeing you. We are seeing you.
Okay, oh, just a minute. Let me just share this.
Shalav is the cataract.
Let me just share the
He's
screen.
a big cat. Cat is that.
Okay.
No,
now you
he's
can see-
not only cataract, he's cataract, retina, everything.
Now you can see this.
Yeah.
So
Yeah,
this
yeah.
this
Yes.
this whitish thing that we see here is what is where the capsule is adherent with the cortex.
Yes. Yes. Exactly. I was telling you that cortical
Yes.
adhesion
So when you
with the,
see,
and that is much more in the harder nuclei.
yes, so once you see something like this in your cataract, then your hydrodissection has to be done to separate
Carefully.
this area. Because the other areas will separate, but this area, which is having this whitish mass, is where the adhesion is more stronger. And this is what you need to actually, cleave. So, okay. So thank you everyone for joining us today. And I'm trying to get others to also join and present their own cases. Are you able to hear me, or I've lost?
Something.
I think there was some problem in the.
So we started recording.
Probably because of unstable network, it just stopped. Okay, so you were able to see that part of the cataract that I was trying to show.
The video also has
It's still some problem with the net. It is unstable.
You can speak.
I think the network is getting disrupted. So we'll call it a day today. And the network is unstable. It is showing. It is showing unstable network. So we will.
Shalav.
Yes, yes. Yes, sir.
I just wanted. Hello.
Yes, sir. Yes, sir.
We are hearing. We are hearing.
We are hearing you, sir. We are hearing you.
Okay, right. So
Our network is
for the-
fine.
Okay, right. For the irrigation port, we have got two holes, 180 degrees apart. They are laterally placed, right?
Yes.
Okay. So if we can have three ports, one directed towards the posterior capsule also, instead of having two, will it not be technically better in preventing the PCR, preventing PCR? If you have three ports, two in the
Dr.
sides,
Anil
and
Shah, Dr. Anil
one
Shah
in the.
developed that, you can buy it. Dr.
Okay, he has
Anil
got it.
Shah has developed that, you can buy that.
Okay.
Yes. Long time back, I think somebody had shown this 3 tips with 3 holes in the irrigation.
Holes, yeah, one towards,
Yes.
one directed towards the posterior capsule.
Yes.
No, that is recently
I
Dr.
think time
Anil
is going
Shah
to be
has.
up. Time is going to be up. So sorry.
No problem.
Good
Enjoyed
night.
it.
Good
Next
night.
day, next step
Good
will
night.
be a 3+ nucleus.
Okay. Okay.
Too many
Thank you.
forms. So we rarely encounter